Sri Lakshmi, are there? Hello? Hello?
Yes, ma'am. I'm here, ma'am.
You can hear me?
Yes, ma'am.
Okay. ठीक है. There's still time, no?
Yes, ma'am. 1 second, ma'am. I'll just.
It's all prepared?
Yes, ma'am.
You can, with that guy, try to see if your slides are running or no. No?
I'll just put my slide, ma'am.
Yeah, just share it. I'll just see if it's showing. Yeah, it's changing also. MRA case presentation. No? Yeah.
Yes, ma'am.
Okay. Okay, stop sharing. I think others
Yes,
will
ma'am.
find a little time. Yeah. Okay. All the best.
Thank you, ma'am.
Yeah, all good otherwise?
Yes, ma'am. All good, ma'am.
I think Akansha's got some references. I told you see, then you can inform later after the case. So, yeah. Okay.
Yes,
Deepti's
ma'am.
on leave, no?
Thank you. Dipti is on leave, ma'am.
How many days?
2 days, ma'am. Monday and Tuesday.
Okay. What's the exact time now? 11? No, 10?
Exact. 1 second, ma'am. Exact time is 10:50, ma'am.
10 minutes more. No, others will join. Okay. Okay. Stay online. I'll get
Yes.
back. Oh, yeah. Bye.
Yes, ma'am.
Hello everyone. Hello ma'am. Hello Kavita ma'am. Hello Varsha ma'am.
Hello, everybody. Good morning.
Good morning. Good morning. Hello sir. Good morning.
Good morning. Good morning. All set?
Yes, yes, yes.
Good morning, sir and ma'am.
Hey, good morning.
Good morning, sir.
Good morning, Dr. Balkrishnan.
Good morning. Varsha.
Good morning, ma'am.
Hello, sir. Good morning.
Hi, Kavita.
Hi, how are you?
Good
Hi,
morning,
Dr.
Dr.
Varsha.
Balkrishnan.
Yeah. How are y'all? All good?
For inviting us
At last
to
raining now.
Yeah. Finally, it's raining here. Here also heavy rain.
So where's Sanat? Sanat also should be.
Dr. Sanat, I'll just call him. I'll just phone him, then we can start. Dr. Balki, you have another lecture also on the other group?
Yeah,
today?
At 12
What time?
o'clock. 12 o'clock.
Well, okay, we'll just start. I'll just call him once. Yeah.
Maybe an idea not to have both on the same day or have a reasonable gap. So whoever wants to listen can. I wanted to listen to Aman also after the case. So, but I won't.
Sorry, sir. What did you say?
I said maybe a reasonable gap can be kept between the two so that whoever, for example, wanted to listen to Aman.
Actually, I didn't know, I got to know very late about this overlaps. So it was too late to
Maybe
change.
from next time, maybe.
Dr. Kavita, how do you keep your sessions? It's the first Sunday.
No, normally it is third Sunday, but there was some time issues. And then like I was in US, I've just come back. So, I thought then this 25th was suiting everybody because I had to communicate with many people. So we fixed 25th long back actually.
Because
Sometime
we
in
have
March.
our sessions on 2nd and 4th.
I know. This is the only exceptional day we have changed it.
Yeah,
Normally
that's
it's
good.
third Sunday. Yeah.
Yeah, because what happens, the crowd also gets divided to some extent, no?
Yeah. No, I know. But then, then the other thing was to cancel it fully. But then I
No,
thought
next time we stick to 2nd,
next
4th,
time
and
I'll take we'll
3rd
just-
or 1st or 5th. Aisa,
yeah. And then September we take a break for MRA Con. And then November again we won't be having. So I thought this session.
Yeah.
Okay. Dr. Sanat said he's joining. Has he joined?
Okay. So what I thought I'd do is I was going to ask both Varsha and Sanat to actually ask the questions and everything when the case is being presented. And
Okay.
in the end, maybe if there's some important points which I think was not covered in the discussion, probably I would come in there. That's the feeling I had. So without, I think, wasting much time, Varsha, I think we should start.
I think we should start.
So we
Yes,
can ask Sri Lakshmi to start presenting the case. And
Yeah.
Varsha can keep asking questions till Sanat comes, or maybe you and
Yes.
I can pitch in until Sanat comes.
What we do is like a complete our history first, and then we ask questions rather than interrupting in
Fair
between.
enough. Fair enough. That makes sense.
Okay, Dr. Shri, you can start sharing your slides. Yeah.
Yes, ma'am.
Welcome Sanat. He has joined.
Good morning, sir and ma'am. Can I start, ma'am?
Yeah, go ahead.
Yeah, please start.
Okay. So good morning. So today I'll be presenting a case with history of young female with fever, rash, hemoptysis, and joint pain. So this is a 23-year-old Mrs. X, who's a housewife, who's BCom, is a mother of one child, 4 months old, hailing from Miraj, came with chief complaints of joint pain of small hands, of hand, knee, and ankle for the past 2 weeks, fever for 1 week, blood in sputum for 1 week, rash over the face, arms, and feet for the past 1 week, and oral ulcers for the past 1 week. So coming to this, I would like to start the history from 2020 as a present condition is a continuation of the previous illness. Patient's first symptom of rash over the cheeks on exposure to sun and she also had history of left knee pain without swelling. She had some difficulty in walking due to the pain, but she was continuing her work normally. There was no history of oral ulcers, and she consulted her physician who advised her to take some topics. In October 20, had a history of cough with blood and sputum associated with shortness of breath on exertion in the form of difficulty in climbing 2 stairs of flight. But she was able to do her home activities. She also gives history that her rash worsened and it also started developing in her forearm, palms, legs, and soles. She gives history of oral ulcers over the palate, and she also had a history of menorrhagia at that time, requiring 1 unit of blood transfusion. She was admitted for the same, given IV medications, requiring oxygen support for 4 days. Post that, she was given some oral medication, which she took 2 in the morning and 2 in the night, and also 1 more tablet. Post taking that, she complained that she had some weight gain and facial puffiness. She was apparently doing well till April 2021, and in April 2021, she had worsening of her small and large joint pain. This time she had more pain in the bilateral knee and ankle and small joints of hand, and lower limbs were more predominant than the upper limb. She had difficulty in doing her home activities like cooking. So she again consulted a physician, and the daily 2 meds was changed to weekly 1 tablet. After this, she was asymptomatic till Jan 2022. But she discontinued all the medication by herself as she was planning for pregnancy. In March 2022, she conceived and shifted to Ayurvedic medication. Asymptomatic throughout the pregnancy. She had early pains and water leak, and this was by LSCS. Now, coming to the present illness, since March 2023, history of pain of joints involving the knee, ankle, and small joints of hand with swelling of both her knee for the past 2 weeks. Her lower limb pains was severe, and she was not able to get up from the floor, had difficulty in using the Indian restroom, and do home activities like cooking and washing vessels. Morning stiffness lasting for 3 minutes, better as the day progresses with activity. She went to her physician this time, and she was started on a medication which she was asked to take and then review. After 1 week, she started developing fever spikes for the which was low grade, 1 to 2 spikes per day, and not associated with chills and rigor. At the same time, she developed pinkish to purple elevated rash on week, and this newer crops developed every 2 to 3 days, and the older lesions were healing with blackish pigmentation. It was not associated with itching or ulcers. And she also developed blood and sputum while coughing for the past 1 on and off, which was reddish in color, not foul smelling, around 1 teaspoon in quantity, around 1 to 2 episodes per day. She also had history of shortness of breath for the past 1 week. Initially, the difficulty was in climbing 2 floors, which progressed to difficulty in doing history of oral ulcer over the palate for the past 1 week. Also, she gave history of generalized tiredness in doing daily activities for the past 2 weeks. There was no history of dryness of mouth, mood disturbances, visual disturbances, sensory symptoms, facial puffiness, pedal edema, bluish discoloration of the hand, thrombosis, or bad obstetric history. Coming to the past medical history, she was diagnosed with connective tissue disorder in September 2022, and probably the medication which she was taking, because she was taking 2 in the morning and 2 in the night, probably could be MMF, followed by which weekly 1 medication probably was Folitrax. And this recent medication history she was started 1 week back could have been azathioprine, because she was asked to take for 1 week 1 tablet in the morning, and then 2 tablets per week. There was history of 1 unit of blood transfusion when she was admitted in October 2022. No past history of tuberculosis. Past surgical history, of connective tissue disorder or arthritis in the family. History of contact with TB in the family. Menstrual and obstetric history, P1, L1, no bad obstetrically. She had menorrhagia till she conceived. Personal history, she had decreased appetite since 2 weeks. Bowel and bladder are normal. Vaccination history, she's taken COVID vaccines in November 2022. Social and economic, she lives in a rented house, and she's able to do a simple day-to-day activities, but finds difficult to do household work at present. So history summary, she's a 23-year-old female with history of fever, hemoptysis with shortness of breath, and rash and arthritis at present. Past history of anemia, rash, arthritis, hemoptysis. Suggestive of connective tissue disorder or irregular erythematosus with disease flare with constitutional symptoms, mucocutaneous, musculoskeletal, lung, and hematological. And considering the DDs for hemoptysis, diffuse alveolar hemorrhage, acute lupus pneumonitis, bronchopneumonia, and tuberculosis.
Dr. Sri Lakshmi, I think she has had 4 flares.
Yes, ma'am.
She has had about 4 times the disease has relapsed. How was she in between the episodes?
Ma'am, actually, she had the first symptoms which started in 2020. So at that time, after 1 month, she had worsening of symptoms and she was admitted and treated. So from 2020 November till the next April 2023, she did not have any symptoms.
She had flares in between, no? October 22.
In April, again, she had worsening in the
I'm not able to hear it. There's some network issue.
yes, ma'am. So therapy.
Actually, we can't hear you clearly. Your voice is breaking.
1 second, ma'am.
Even during the history, it wasn't very clear.
You're able to hear me now, ma'am?
Yeah.
Yes, ma'am. So yes, ma'am. So initially she was asymptomatic till 2021. Then she had worsening of symptoms in the form of arthritis. She had bilateral knee pain and small joints of hand. She had difficulty in getting up from the
the history. I just want to know in between episodes, how was she doing? Was she on any regular medication, on regular follow-up?
She was on regular follow-up only till 2022 Jan, ma'am. After 2022 Jan, she discontinued all the medications by herself because she was planning for pregnancy. And from that time, she switched on to Ayurvedic treatment. And post her childbirth also, she was not on any medications since November 2022 to March 2023. She was not on any treatment, ma'am.
So on history, what do you think is your diagnosis? How would you approach this patient?
Yes, ma'am. History-wise, I'm seeing this patient having constitution.
Again, her.
Your voice is cracked.
We've lost Shri. Shri, we can't hear you. Hello.
Along with the arthritic component, that is.
No, Shri, we couldn't hear you.
Hear me, ma'am?
Yeah, now, but
Hello.
we couldn't hear anything before that, what you said.
Yes, ma'am. I'll start from why I'm thinking of SLE, ma'am. You're able to hear me, ma'am, now?
Yeah.
Yes, ma'am.
What is your diagnosis and why? Yeah, on history.
Yes, ma'am. On history-wise, my diagnosis is systemic lupus erythematosus. The points favoring in this patient is an acute photosensitive rash, which is present over a face, palms, and sun-exposed areas. Second point is favoring connective tissue disorder is the arthritis involving bilateral knee and small joints of hand. Third thing, which is supporting the diagnosis, is her lung symptoms, which basically is she's having hemoptysis. The probability of hemoptysis in this patient, I'm thinking it could be a diffuse alveolar hemorrhage, or it could be acute lupus pneumonitis, or I would like to rule out infections like tuberculosis or bronchopneumonia in this patient. And also a past history, which is suggesting of similar complaints of photosensitive rash with arthralgia, and also history of similar episode of hemoptysis suggests more in favor of a connective tissue disorder like systemic lupus erythematosus.
So with the past history of hemoptysis, rash, joint, and lung, why are you discounting vasculitis in the history?
Yes, sir. So,
Because hemoptysis per se is not that common in lupus.
In lupus,
Extremely
exactly.
rare entity.
Right,
So
yeah.
if somebody with lupus gets hemoptysis, how would you approach it mentally? What would you think of?
okay, sir. So in this case,
Not
first
this case,
thing,
supposing it's a lupus and the patient
Okay.
is a known lupus and he's getting hemoptysis. So what are the few important things you would think of? Number one,
okay, sir. For first one, if the patient is immunocompromised status and if the patient is already on immunosuppressive drugs, I would like to rule out infective causes first.
very good. So
like,
first would still be infection. Out of
Yes.
10 patients with a patch, lupus with a patch in the lung, 8 out of 10 would be infections.
Infection.
And
That is the most
then the other
common cause.
differentials would come. What would be the other thing you would think of? Common things first.
Yes, sir. So first thing, after ruling out infection, second cause I would think of lupus pneumonitis.
That's very
Uh,
rare.
Yes,
And
sir.
usually
second-
does not present with
Yeah, yeah.
hemoptysis.
The other thing which we forget is thrombocytopenia, epistaxis, and bleeding and all that. It can
Yes,
go
sir.
into the lung and you can cough it up. Actually, it
Yes,
might
sir.
be coming from the sinuses. Okay, third, anything else?
Associated with SLE, we can think of APLA-related complications if the
Right,
patient is
sometimes,
APLA
yes,
positive,
infarct,
like
yes.
pulmonary infarctions. Then the
Right.
patient can
Yeah.
present with hemoptysis.
Anything else?
Apart from this, also cardiac causes we have to rule out because
Very good.
patient
Pulmonary
can go
hypertension.
for pulmonary artery hypertension, and pulmonary edema can also develop in the patient.
Very good.
That can
So
also lead
I
to
would probably
hemoptysis.
think of these first rather than lupus pneumonitis. Lupus pneumonitis is very rare and it's a diagnosis of exclusion. And more
Yes, sir.
likely that it's a pneumonic patch due to an infection than lupus pneumonitis. And also past history, because India TB is common, other things which are unrelated to lupus could also be causing the hemoptysis in this patient. Right. So that's
Yes.
maybe a few things that good. The important thing is rash in this patient, isn't it? And many
Yes, sir.
times patients with SLE are on, or before we diagnose them, are on many medications. So how would you differentiate between a drug rash and a lupus rash?
Okay, sir. So in case of a lupus rash, it is more present in the photosensitive areas like the cheeks, in the arms where the sun exposed areas, and in the feet where there is sun exposed areas. That is one point that favors a SLE rash. Whereas drug rash, there is a history of starting a drug, and the rash is generally truncal, and the distribution of rash is more truncal in case of the drug rash. And in SLE, apart from the photosensitive rash, few of the rashes like discoid lupus rash can cause scarring, and that is very goes in favor of the SLE rash.
The other thing
And
is, if you have a good malar rash, if you have other rashes, DLE, typical of SLE, it is easy. Sometimes if it is not there, one of the things you have to think of is that a drug rash, all of them have the same history. They all started at one time, and by the time you're seeing them, the morphology of those lesions will all be of the same nature 7 days down the line. Whereas in an immune complex mediated connective tissue disease, you get waves of rash like this lady had. You also
Yes, sir.
said in your history that somewhere healing and somewhere new.
Somewhere,
That's
yes, sir.
very typical of a connective. It can occur in drug rash, not that it cannot. Can occur in immune complex mediated drug rashes, but more often than not, it's due to the underlying disease than a drug rash. So that's because you gave it in the history, I thought I'd pointed it out, because your history of rashes of different morphology there and different duration. It is very important to pick up.
Yes, sir.
How would you describe the arthritis, the inflammatory joint pains in one word? If you have to differentiate it from lupus or vasculitic joint pains from rheumatoid joint pains, in one word, how would you differentiate? What is the main differentiating feature of arthritis in lupus, vasculitis, and in rheumatoid?
More erosive, destructive arthritis is rheumatoid arthritis.
This is non-erosive and non-deforming.
Non-erosive, non-deforming.
You never see a lupus patient with joint deformities, right?
We can see it is like Jacob's like arthropathy, where the patient can appear like deformed, like looking like
reversible deformity.
it is reversible
Which
deformities.
is not the same in rheumatoid, right? So
Yes, sir.
why is it reversible deformity? What is the difference?
Because basically
Why is there deformity then, if there is no damage?
Because of the ligament laxity, the patient goes in for the non-erosive arth, which is reversible.
Correct.
So if you had caught this lady in so if you had caught this lady in March 22 when she had a previous episode of hemoptysis, what would you have done differently to prevent this further worsening, do you think?
You're saying the current episode, sir, or the previous episode when she had like last admission?
No, if you had caught her in March 2022.
Yes, sir.
What would you have said to her, and what would you have done differently so that she wouldn't have come back?
Yes, sir. One thing is, we would have advised her not to stop
another
her
hemoptysis episode.
Yes, sir. So one thing is maintaining the disease into remission, sir, because she had lost her follow-up and she had stopped all her medication during her pregnancy, which was a precipitating factor for another SLE flare this time. So, that was the important thing. And second thing is, if the cause we are suspecting it as infections, we could have given her vaccinations before to prevent another episode of bronchopneumonia.
Right.
Any neurological symptoms did the patient have in the history, throughout the history?
No, ma'am. She did not have any muscle weakness. She did not have any sensory symptoms, and she did not have any other sensory symptoms.
So what happens to lupus in pregnancy usually? How do lupus and pregnancy interact? So you can tell me in both ways what lupus does to the pregnancy and what pregnancy does to the lupus. The latter I'm more interested.
Okay, sir. So what happens in pregnancy is, as such per se, lupus to the pregnancy does not cause any infertility. It can cause subfertility. But the disease as per se can flare up during the pregnancy. This is mainly because because of the hormonal effect. The patient can go for worsening of the lupus symptoms, and also the patient can have lupus nephritis. There is a higher chance that the patient can go in for worsening of the lupus symptoms.
Okay, so what percentage of lupus would you, if a person who's recently pregnant came to you and said that I'm now pregnant, what would you tell them? How likely is it that they'll suffer a flare, and when do you think they'll suffer a flare, and what kind of monitoring for a flare would you ask them to do?
Yes, sir. So basically, the patient goes in for flare in the second trimester, and we would like to monitor. We will advise them that during the second trimester, we can advise them what are the signs and symptoms they should look for during the second trimester of the pregnancy. So we should advise them if they are developing any pedal edema, facial puffiness, early signs of headache or visual symptoms. Then we should advise them to come to the to come for more frequent follow-ups. And also we should monitor their complete blood count, urine routine, urine spot PCR, ESR CRP monthly, so that we can get an idea whether they're going in for remission at an early time. And we should also advise them for other signs of flare in pregnancy. And also basically we can tell them that around 40 to 50% of the patients will go up for the lupus flare during the pregnancy, and that we can give them the guidelines, like these things has to be monitored, like the blood pressure, their urinary routines, and all these has to be monitored routinely so that they did not go in for any further flare. And also we have to advise them before getting conception that before 6 months at least they are in proper remission, so that they do not have any worsening during the pregnancy phase.
One important thing is ESR may not be a very good ESR may not be a
pregnancy
marker for activity in pregnancy. So don't depend on ESR, depend on the clinical features, the C3, which is very important. CRP is often again not very reliable during pregnancy. And I think 50% is a bit too much. If it's well controlled, it's not around that much. The ones with lupus nephritis who are controlled and go for pregnancy have worse prognosis during pregnancy, including pregnancy loss, and even after birth, they have problems. But I don't think it's 50%. It might be a little less, even in India.
25% is what I remember.
That's the figure.
Yeah. And also, I mean, one important thing is the change of medications that you will want to do if a person who is pregnant comes to you, who's with lupus comes to you with pregnancy. So, with pregnancy, that is the one other point that you must touch upon.
I think you should go on with your
maybe should we? Yeah. Examination.
Case findings.
So on examination, general examination, she is thin built, height of 150 centimeters and weight of 40 kg with BMI of 17.7 kg. With moderate pallor present, no icterus, cyanosis, clubbing, pedal edema or lymphadenopathy, JVP not elevated. Vitals, temperature 99 Fahrenheit, pulse rate of 130 per minute regular with high volume, blood pressure of 90/60 in both upper limbs, respiratory rate of 24 per minute. Saturation was 85% at room air and 97% with flow liters OD. Examination of the system skin. She had papillomacular lesions of 3 to 5 mm size and few coalesced with irregular border present over the face, forearms, palms, and soles. Few lesions are hyperpigmented and resolving, and few lesions are new. Different stages of lesions are seen at the same time. Oral ulcers, there was one oral ulcer over the hard palate. Musculoskeletal system examination. There was tenderness, swelling present in bilateral knee and ankle. Tenderness present in the right, second, and third MCP, left, second, and third MCP, and second PIP joint. No deformities present. Restriction of active joint movements in knee due to pain. Other joints, no restriction of movements. Systemic examination. I would like to start with respiratory system. Her single breath count was 22. Inspection, thoraco-abdominal, both hemithorax moves equally. Trachea appears in midline. Chest expansion was equal in all regions of chest. Skin over the chest was normal. On palpation, trachea and the midline was confirmed. VF was equal in all areas. No palpable creps and rubs. Chest expansion was 4 centimeters. Resonant in all lung fields. On auscultation, the vesicular breath sound was heard in all lung regions. Occasional creps in bilateral lower lung fields, infrascapular and infraaxillary areas. Vocal resonance was equal in all areas. Cardiovascular system, the apex beat was felt in left fifth intercostal space with first and second heart sounds heard. No murmurs, added sounds or ejection clicks. Abdominal system examination. The abdomen was not distended, flanks were free. It was soft with no organomegaly, no free fluid, bowel sounds was heard. Central nervous system examination, higher mental functions were intact. All cranial nerves was equal and normal. Motor system, tone, bulk, muscle power was full. All reflexes was normal. Sensory and cerebellar examination was normal.
Over 20 minutes.
My differential diagnoses are in this patient: systemic lupus erythematosus in flare with diffuse alveolar hemorrhage, musculoskeletal system arthritis. Neutropenias.
I think it's
there's some.
Miss Arpana Reddy can switch your phone off, please. Or mic off. Thank you. So before you go to the management, can you go back to the diagnosis part, past the last one?
Yes.
Differential. Now again, I would be a little careful because clinically when you examine the patient before your investigations and everything, there was the important factors was there was hypoxia, which improved with 4 liters of oxygen, and that tells you that there was significant lung involvement. Cardiac wise, there was no failure, there was no you couldn't make any valvular problems, nothing. Nor did you have any symptoms features to suggest pulmonary hypertension. So there was definitely a pulmonary parenchymal event which was going on, which had caused a significant hypoxia. So yes, diffuse alveolar hemorrhage is one possibility, but don't forget infections.
Infections.
So please, I mean, because that is much more common than, again, I'm repeating
Yes,
it.
sir.
In lupus, to get a diffuse alveolar, it is known, it is seen, we have seen them, but it's rare. So you have to be careful. And I would probably still think of an infectious cause rather than just putting DAH
diffuse.
straight away, because we don't
Yes.
have investigations with us.
Yes, sir. The only thing which taught me to put as diffuse alveolar hemorrhage rather than infection was on examination of the RS system. I did not find any deviation of the trachea to suggest
Very
cavitatory lesion, or there was not
Very
any consolidatory changes. I could not hear any auscultatory findings, or there was percussion. There was no other stony dullness.
But still, when there
yes,
are
sir.
multiple infections on either side,
Infections.
you might not still get
Not-
a bronchopneumonic features with bronchial breath sounds. You may not get them.
Yes, sir.
You have caught them pretty early, so therefore you may not still get them. So I would still.
In fact, yeah.
Was there
In fact,
fever
these two
there?
things are sorry.
Was fever there? Did the patient have fever?
The patient had fever, ma'am. Patient had
Yes.
fever for past 1 week.
These two
But,
things are actually very difficult to differentiate anyway, infection and diffuse alveolar hemorrhage, even on CT scan. They almost look completely the same.
And yes,
So,
you said there was a past history of similar hemoptysis.
Yes, sir.
Diffuse alveolar hemorrhage in the past would not just go away just like that.
Right.
Yes, heroic measures were done at that time. So that it could have just been some bronchiectatic element with secondary infection is still a possibility. So therefore, infections would be, in my mind at least.
It still be first, yeah.
Yes.
Right. So then we go on to the investigation. So we know that this is SLE. So I'm to try and cut it a little short and have a little bit more discussion. I know you'd have done all the tests. What are the investigations you've asked for this patient?
So this patient, since she had pallor, I would want to see her hemoglobin, and I would also see her platelet levels because previous history of menorrhagia in this patient. Apart from that, I want to do a ESR level to see for the active disease activity status. CRP, if there is a possibility of infection, then that could also be raised. So CRP. LFT and RFT. LFT to see if there was transaminitis, and RFT to see if the creatinine was normal or if there was any involvement of lupus nephritis. Apart from this, I would like to do a chest X-ray initially to see if there is a gross consolidatory changes or if there is any infiltratory changes. Urine protein and urine spot PCR again to see for urine proteinuria, and also to see if there is any active RBC and RBC cast, and urine spot PCR to quantitative the proteinuria. C3, C4 to see the disease activity level. DSDNA by ELISA titers again. If this patient is the first time appearing to us, then ANA by IFA, EMA, and an APLA workup should be done to see to confirm the diagnosis. If she has already done, then this could be skipped. Apart from this, HRCT is warranted in this patient because we have to need a clear-cut picture whether it is a consolidatory changes or infection, any cavitatory changes, or it's diffuse alveolar hemorrhage. If the patient is vitally stable, then we can go ahead with PFT and DLCO. These both will help us differentiate between an infection and an diffuse alveolar hemorrhage. Because DLCO might be elevated in case of alveolar hemorrhage. That can give us a clue. As well, I want to rule out the infection in this patient. So sputum for AFB, gene expert, gram stain, and culture. If any organism is growing in this, then accordingly we can treat it with antibiotics. And if the patient is negative for all of this, then bronchoscopy is warranted. To look for, again, can send for a gene expert and a gram stain and culture, and also to look for hemosiderin macrophages to see if the patient is having an alveolar hemorrhage. So these are the basic investigational workup I would do for this patient, and also a 2D echo to rule of cardiac causes.
Important thing is sometimes the patients don't give you time to do everything. They might directly come and go onto a ventilator if they are very hypoxic. So sometimes putting out the ball, waiting for just normal sputum reports to come may not be a good idea. If the patient is needing 4 to 6 liters of oxygen and there are shadows in the lung, you might as well get an early ball done to give you what is happening rather than wait for. So yes, you're always you're in the exam taught to tell this in sequence, but in practical, when you're treating patients, you would probably hasten and do a ball much before doing anything else, because that really tells you the difference. So what are the radiological features that will make you think that this is pulmonary hemorrhage?
Usually there is in the CT or X-ray changes, it is a bit of a gray zone, because the both sides there can be diffuse infiltrates on both sides of the lung fields.
Have you seen diffuse alveolar hemorrhage on X-ray and CT?
Yes, sir. I have
Okay.
seen.
By and large, if they are going enough to cause hemoptysis with reduction in hemoglobin, I know that nothing is specific. But by and large, they are central. There is peripheral sparing, and you have to rule out other causes like failure and other things, and then say this. Because why I'm telling is, you may not have time for everything. So you have to sometimes treat both. So you will have to give an antibiotic, because if the patient is on a ventilator, you will not be able to do a ball. Nothing can be done.
Right.
There are shadows on both sides. So sudden fall in hemoglobin, right, along with a central shadow, where you rule out congestive heart failure, and then in the end you end up treating both many times. If the patient is sick and on a ventilator, you end up treating both of them. So therefore, it's by more often than not in the central bilateral, with sparing of the episis and the and this thing, and you have to rule out other things too, including failure. Won't you do an anchor in this if there is pulmonary hemorrhage?
In this particular patient, history-wise, the rash, photosensitive rash.
No, it is lupus. Would you still
sir.
do an anchor, MP3, PR3, MP, or if the patient, for example, had renal involvement with crescents, would you still ask for them? Overlaps are known, so there's not
overlaps are known.
Yes.
So of sending a PR3 and a MPO
just the treatment may not differ, but you will know something else is happening.
Yeah. Dr. Varsha, Dr. Sanat, would you like to?
Are you done with the case?
Last slide is a management.
Okay.
So,
the investigations, you told us you would do this, but what were her reports like?
Ma'am, for her, she had a hemoglobin of 7. ESR was 100 and CRP was also elevated. Apart from this, her HRCT thorax showed a bilateral.
WBC and platelets?
TLC count was around 12,200 now, and platelets was around 1.2 lakhs. It was not very much elevated, and we had also done a DCT. DCT had come positive for her. Also, C3, C4 complements were very low. Her dsDNA titers were positive, and the blot workup had showed SM, UNRNP, and Rho positivity. Apart from this, a 2D echo was normal, and we did not go ahead.
What is the dsDNA level?
dsDNA was around 200, ma'am, titers by ELISA.
Okay. And complement low meaning? How low were they?
C3 was around 60 and C4 was around 4, ma'am.
Okay. Fine.
Her urine routine and urine spot PCR did not show proteinuria or RBC and cast. So renal involvement was ruled out. And 2D echo was normal, and bronchoscopy we could not do for this patient because she had desaturations and yes, sir. And we had repeated the HRCT twice. Initially, when her HB was 6, it was showing ground glassing with pulmonary infiltrates, and she had persistent dropping of hemoglobin, which went up to 4. So, and one more HRCT thorax was done after 2 weeks, showed increasing in the ground glassing as well as of the infiltrates, which was suggesting of more of diffuse alveolar hemorrhage. So for this patient, we went ahead with the IV methylprednisolone pulse, and also we had covered her with IV antibiotics because infection was also one of the in the list, and we had to decide between cyclophosphamide and rituximab. Due to financial constraints and also after discussing both the options with the patient, we went ahead with cyclophosphamide regimen. And in hospital, she received the first cyclophosphamide dose, and later monthly doses was planned for her. After the IV methylprednisolone pulse therapy, she started improving. And within, actually, she took around 2 weeks course. After the first 3 days of pulsing with 1 mg per kg oral maintenance, we had continued. And after 2 weeks, her hemoglobin started stabilizing. That is after giving the cyclophosphamide also. And then she started improving. So currently she's on cyclophosphamide monthly regimen.
In few things, one is I think you are fortunate with this case because she just had lung involvement and no renal involvement. Many times there is also a rapidly proliferative glomerulonephritis going on. That's number one. Second thing is she gave you time too for you to do a repeat HRCT to see that it's worsening. Many patients don't do that too. So you have to be, you might need to catch them early. So early bronch is always of great use if possible, if hypoxia is not a problem. Third thing is many use plasmapheresis when this is going on, and that's still the jury is out whether it's really useful or not. Large studies are not there, but it seems to help, especially when there is a pulmonary renal thing going on. They do use it. So that's and cyclophosphamide amongst many of our immunosuppressants seems to work reasonably fast. In fact, rituximab might work a bit lesser, much slower than cyclo. Cyclo works within 7 to 10 days. So that's not a bad
slow,
thing. And because her renal function was good and creatinine was normal and urine output was normal, then you don't have to think in terms of reducing the dose of cyclophosphamide, which is often needed when there is a renal involvement, renal impairment, reduced urine output, and a creatinine of 4. Although one would hazard a guess and say that creatinine is because of active renal involvement rather than a chronic renal, and therefore even giving the full dose of cyclophosphamide is not a bad idea, and keep monitoring. Also, what regimen would you follow in this patient?
We followed the NIH protocol.
Why not the Eurovas? This is something like a
Right.
cute thing, and you're not wrong to follow either. And now many are following every 2 weekly 500 rather than following the NIH. Reason is getting a quicker control, and then you can switch to less toxic drugs later on. So I think even that is not a bad idea.
Giving every 15 days works faster than giving once in 4 weeks.
Yes.
Actually, for this patient, initially we had started her on monthly 1 regimen. And after the second dose, since she was persistently having low, the HP was dropping, we shifted her over to 15 days 1 regimen. And she's currently completed 4 cycles of cyclophosphamide 15 days once.
You're fortunate because the patient is giving you time, is allowing you to learn. Sometimes they do.
How do you explain the drop in hemoglobin?
Ma'am, in this case, actually, two reasons we can think of. One is actually her direct home stage was also positive. So there was a background autoimmune hemolytic anemia also running. And second thing,
retic count?
retic count, I think it was around 5, ma'am. I'm not sure. I have not noted it in the slide. And
I mean, that would tell us whether the drop in hemoglobin is because of the Kunz and the DCT being positive. No?
Yes, ma'am. That was one of the reasons. But here we had evidence that after 2 weeks of CT, there was a worsening of the infiltrates. So that was also giving us a clue that it could be as well as a alveolar hemorrhage.
Bleeding related.
So when you talk about the CBC, you should always stress in patients of lupus on the lymphocyte count.
Yes.
So if you do an absolute lymphocyte count, that also goes in favor
lymphopenia.
of so lymphopenia is what you should stress when you.
Yes, ma'am.
One more way of differentiating it from vasculitis is that in vasculitis,
so
you have more
would a reticulocyte count of?
Yes, Anand, continue.
Oh, sorry. Now, what would a reticulocyte count of 5 tell you within these two? Which way is it veering the current reason for anemia?
If the reticulocyte count was increasing, then it goes in favor of more of hemolysis picture.
No, so you've already told me 5. So what would a reticulocyte count of 5 tell you? Is it, you already have this patient, you already have her investigations. So if she's come with a reticulocyte count of 5, would you say this is because of blood loss, or would you say it is because of hemolysis?
I would say more in terms of hemolysis, sir.
Why? No, so basically, I mean, firstly, you need to correct it. You need to do a reticulocyte production index. And if I remember correctly, her hemoglobin was 7. So it comes down to 2.5 directly. And
Yes, sir.
I would assume there was polychromasia because there is some blood loss. So it would come down even further to 1.25%. So it is unlikely that there is the ongoing hemolysis is significantly associated with
Association.
anemia. So 5, I would think more in terms of blood.
Blood.
So the other problem here for blood loss, can't really rely on ferritin because it is high in inflammation, and you can't, and the iron is not completely gone out of the body; it still remains within the body. So blood loss anemia from the capillaries, you can't say that it will be associated with everything else which is associated with the blood loss anemia. Yes.
Would you add on with hydroxychloroquine sulfate or no?
This patient, she was already on, we had started her on hydroxychloroquine. Ma'am.
So how are her parameters as of now?
Ma'am, currently she's currently completed 4 cycles of cyclophosphamide. First one was, we started with a monthly 1 regimen, but last 3 doses we had given in 15 days interval. And currently her hemoglobin is stable at 8. She actually required a total of 3 to 4 transfusions. And her compliments, we have not repeated yet. She'll be coming next week for the repeat and compliments. But we have repeated her a pulmonary function test and a DLCO, which was showing that pulmonary FEV1 was around 79% and FEV1 by FVC was around 80%. And her room air saturation was 98%, and 6-minute walk test, she did not desaturate or have a tachycardia.
That's
So
fair.
all this, so currently after monitoring her lung vitals, it looks like she's improved and she's responding to the treatment, and she's on oral maintenance prednisolone on tapering doses. She's currently on 15 mg prednisolone, and she's fairly doing okay, ma'am. Her HB is stable right now.
What did you tell the pattern of ANA was? I didn't get that. The ANA was
she had a coarse speckled pattern, ma'am. Strongly positive. It was 3+, ma'am. We did not have a title. We had done by intensity, 3+.
What do you think about Mesna? She's a young lady. She's had 1 child. She may plan another pregnancy. So what do you think about Mesna? What do you think about ovum? What do you think about her future pregnancies? Did you discuss this with her?
Yes, sir. We had discussed with her. One thing which was currently was already she was amenorrheic post partum. So after discussing with that, the chances that she's since she was already amenorrheic, this is the best time to give her the cyclophosphamide also. And
yeah, I'm talking about future. I know she was amenorrheic now, but she might wish a pregnancy sometime in the future. So you have to discuss with them all this before you
start the cyclophosphamide.
What do you think the chances of infertility are in this age?
Sir, considering her age,
with a full NIH protocol.
Yes, and considering her age, 20 to 23, the probability that she might go for an ovarian failure at this age is comparatively low. Comparing with someone who is around more than 30+, where the ovarian reserve failure chances is high. So she has a good chance that her ovarian failure rate is very low in this particular.
What was the
she'll ask you what is.
Sorry, what was the rate reported by the NIH study? What do you know? Have you read that study? No. Who were the authors of that NIH study? Do you know them? You need to know these things. These are very important studies. Austin and Bompas, they were the ones who really did the NIH study for the lupus nephritis. Yes. And there they found later on that about 40%, if I'm not mistaken, were amenorrheic at the end of 2 years. After 6 monthly pulses and 3 monthly pulses extending for 2 years, 40% of them were amenorrheic around, and half of them, after stopping the 2-year therapy, the menses were regained. So it's not as if it's a very bad this thing. Yes, and age is one of the most important factors for this. So, like you rightly said, older you are, more chances that you will go into amenorrhea, which is long lasting.
Dr. Aman wants to ask a few
Yeah,
questions.
Dr. Aman is welcome, Dr. Aman.
Thank you, madam. Thank you very much. The nice presentation, Dr. Sri Lakshmi. Couple of
Thank you,
questions
sir.
which come to my
Yes,
mind after your presentation, and a few comments. The first question is, any other thing which you feel we need to know or we need to be careful about in future pregnancies, given the results that she's had? And specifically that you will keep an eye on. The second one is, what is your take on the spectrum of clinical manifestations that diffuse alveolar hemorrhage can have? I mean, it can, what is the spectrum? Can you, as a rheumatologist, you need to have that at the back of your mind. These are the first two initially. I mean, although the other points have already been, most of them have been clarified, which came to my mind. You can address these two.
Yes, sir. So the different clinical spectrum which we are thinking, clinical spectrum when we think of diffuse alveolar hemorrhage coming to us is rheumatological and non-rheumatological. So first, as non-rheumatological, as we were discussing initially.
No, I'm not saying as a, what is the cause?
No, that's,
say, for example, I mean, the issue is, let me put it as a comment. The thing is that diffuse alveolar hemorrhage might be very absolutely asymptomatic, and the patients might just present with fall in the hemoglobin, which might be picked up on radiology, but which may not also be picked up on radiology because these are episodic and there are fleeting, infiltrates which might be seen. And on the other spectrum is the disorder which can be rapidly fatal, as Sir Balki sir said, I mean, requiring oxygen, requiring ventilation, and you would have to be very aggressive. So the spectrum is from asymptomatic, relatively asymptomatic episodic disease, which might translate into an interstitial lung disease kind of a presentation, both in ANCA and in lupus patients, to a spectrum where, although I agree with that this is very rare, but it might just be happening without producing any clinical symptoms, with only one thing present, which is fall in the hemoglobin, which comes up, goes down again, comes up, goes down. And if you're fortunate, you might have some imaging in between, which would show those changes. And as Sir had pointed out, perhaps you said that there were increase in the infiltrates, but what we would be more interested is that whether there is a classical peripheral sparing on the CT. If you see the CT cuts, that is one thing which kind of is a subtle one tick in favor of it being a lung hemorrhage and not being an infection, whereas infection might just be unilateral. Although what compounds the entire picture is that rarely you might have lung hemorrhages also becoming unilaterally, but those are one of the most difficult situations where perhaps you end up treating for both. We can't be dogmatic either way. The other, you said the patient is Rho positive, is that correct?
Yes, sir. She was Rho positive.
That is another thing which you will probably be careful if she plans to conceive again, and the monitoring. So what are the monitorings that you need to do?
We need to monitor her.
Positive.
Yes, sir. So in Rho positivity, we need to monitor the fetal heart rate. From the early, like 4th, 5th month, we need to start monitoring the fetal heart rate. If there is
no. Since when?
Since when, and how frequently you do, and what do you do, and what you look for? It's not just a heart
24,
rate.
24 weeks.
Well, it is much earlier than 24 weeks. It's not 24 weeks.
16 weeks you would start, yeah.
16 weeks you need to start not the monitoring. Initially, it is free. I mean, you need to know the frequency, whether you'll do the fetal echoes every 2 weekly or every weekly. And you need to have that cardiologist into the picture, the pediatric cardiologist or whosoever is there in the picture. And then you might have to intervene at some point in time. I mean, you need to know, although there are no proven effective therapies, but one needs to be careful. And this is another aspect that perhaps you will have to keep in mind.
Actually, I'll just interview here. Dr. Balki has another talk in another 5 minutes. So you can just give your feedback or one question, then we'll continue.
No, I think she has presented very well. This is a lupus patient presenting with pulmonary hemorrhage, which is not a common presentation. I think she's done quite well, and you will see more and more patients over a period of time, and then get more, I would say, more experience with these sort of problems. And I'm sure she'll do well. I don't think there's any problem. So I thank everybody. And unfortunately, I have to go for a talk elsewhere. I would have loved to listen to my friend Aman. I'm hearing him talk after a very long time. So maybe
I'm sorry there was a clash here.
Somebody can record the thing and
yes,
probably.
yes.
Thank
share
you.
both the talks. Yeah. Thank you, sir. Thank you so much. Yeah.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Yeah. Okay, so I think others can continue for a while before we start. Dr. Varsha and Dr. Sanat and Dr. Aman, you can ask a few more questions, give a little feedback, then we'll start with Dr. Aman's talk.
I think it's a job well done. I mean, there are a couple of things which came to my mind. The other things which he perhaps would need to tease out are the lupus specific. Since this patient had a rash, I couldn't figure out because it's a small laptop, I couldn't figure out the kind of lesions. But two things she would probably need. I'm sure she already knows what are the lupus specific or lupus non-specific rashes, and what are the various clinical. I mean, the clinical scoring systems for the skin rashes in the classy and modified.
Yes, so we have the lupus specific lesions and non-specific lesions. Lupus specific lesions, we have the acute cutaneous lupus, we have the generalized form and the localized form. And in subacute cutaneous lupus, we have the papillosquamous lesion and we have the annular lesion. And in chronic, we have the discoid lupus lesions. Apart from this, the non-specific lesions will be like alopecia, chilblains. Apart from that, other lesions which will be classified Rowell syndrome. These lesions will be classified as a non-specific lesion.
Reticularis, erythema nodosum,
lupus timidus. And yes, sir. And for the monitoring of the disease activity and the scoring, we have usually we use the SLEDI 24K and 2K. And we use the last 30 days disease activity scores, and we score them accordingly, and we classify them as mild, moderate, and severe criteria based on the score. And apart from this, we also have the other scoring systems like the BLI scoring system, where we have the classification according like A, B, C. Whether they are persistent, new onset symptoms, or
I was asking you was class C for the skin involvement. So, these are the measures for the overall disease activity. But CLASI, the class C is for basically for
cutaneous lupus activity.
Okay, that's all that. I think good job, well done. I think that with that, I think I'll probably try to.
Yeah, Dr. Sanat and Dr. Varsha, would you like to ask?
It's done really well, yeah. It's done well.
Thank you,
Yes.
ma'am.
Yeah, Dr. Sanat, any more questions?
No, I think, we can. I was very happy with the presentation. She presented really well, very systematically. Only thing I would say is I would not cut out all the other things from the differential diagnosis at a very early stage. So if you're asked differential diagnosis right after a history, then don't commit on lupus, especially when it's such a case where there's alveolar hemorrhage. So I would still keep considering vasculitis and other causes of pulmonary hemorrhage at that stage at least.
Okay, sir.
So later, of course, your examination helps in narrowing it down. And that is something that you can show, because otherwise the examination is a futile exercise if it doesn't narrow down something if it's absolutely the same, if your differential diagnosis remains the same from your history to after your examination, then there's not much that it's given you. So you should be able to sort of take one thing at a time and then add to your differentials or subtract.
Multi-system involvement with the skin, lung, and joint. Multi-system involvement with involvement of the lung, skin, and joints. And first diagnosis would be lupus, but I would always like to rule out
vasculitis.
Yes. Rather than saying it is.
Even much broader things like HIV and things like that would still fit in a symptom complex such as this. So it would help to have it helps in the discussion of your examination and where your viva goes.
Yes.
But
Thank you,
you could answer
Yeah.
most of the questions. So good presentation.
Thank
All
you,
the
Dr.
best. Thank you, ma'am.
Varsha. Yeah, thank you,
Yes,
Dr.
definitely.
Sanat. Thank you very much. Dr. Shri, you can stop
My
sharing your
pleasure.
slides.
Yes,
In
sir.
the
Yes, ma'am.
meantime,
Dr. Kavita, thanks for inviting us.
yeah, you're welcome.
Thank you.
Yeah, so I officially welcome Dr. Aman. Everybody knows Dr. Aman Sharma. He needs no introduction. But for those who don't know, he's a professor at PGI Chandigarh and one of the most famous rheumatologists of the country. He's been awarded the API Rabindranath Tagore Oration in 2019, V.R. Joshi Japi Award for Outstanding Referees, R. Subramanian Endowment Oration, multiple awards. NI, MAMS, NI Grand Rounds on Systemic Vasculitis and Relapsing Polychondritis. At present, he is the IRA Secretary, and he delivered the IRA Oration in 2015, Zydus Oration in 2011. He received the Young IRA Investigator Award in 2007 and Eminent Mid-Career Rheumatologist Oration 2018. He has 496 scientific papers, 66 book chapters. He's the founder of Indian Vasculitis Registry, which is a really pride for all of us. Indian Relapsing Polychondritis Registry, IRPR. He's written multiple books, many of which we have read and are really special for the students. I thank you, Dr. Aman, for accepting the invitation today. I request you to talk on ANCA vasculitis. There are already some questions in the chat box for you. So please take some time to answer them at the end of the talk. Over to you, sir.
Thank you, madam. Thank you for this very kind invitation. It's always a pleasure to be with the Maharashtra Rheumatology Association. I'll thank you and the association for this opportunity. And in the next, are my slides visible?
Yes. Yeah.
Very well.
Very well.
So
yeah.
How do we, is it working from
Just
here?
It's moving forward.
No
yes.
problem, no problem. I'll just give me a second.
Yeah,
I think
sure.
these are my disclosures and nothing really which conflicts with what I'm going to speak about. I'm straight away going to the topic which has been assigned, ANCA-associated vasculitis, and as we are already all aware that Chapel Hill, as per the latest Chapel Hill nomenclature system, this is amongst the small vessel vasculitis as far as the 2012 class nomenclature system. So how do we really differentiate these ANCA vasculitis clinically? We've already listened that there can be renopulmonary involvement, there can be skin rashes, as were there in the patients that patient that was presented. But what is more important is that whereas the ENT manifestations are dominant, like nasal crusting, nasal obstruction, nasal ulcerations, collapse of the nasal bridge, with hearing impairment or CSOM kind of a history with grommet recession, which occurs in GPA. There is history of asthma with sinus involvement in eGPA. And on histopathology, both these two have granuloma, whereas these things, upper airway involvement is not seen in the microscopic polyangiitis. So we all aware that there was an DCVAS study, which in 2015 brought out a draft criteria wherein they had clinical criteria and the tests. And if somebody had a score of more than 5, and the 5 was simple 5 was given for PR3 positivity, then somebody was diagnosed as having GPA. So at that time, in 2000, we presented our own data and we showed, this was one of the ACR meetings, we showed that this was pretty heterogeneous and these criteria were not really homogeneous, and there was no renal, the renal involvement initially in the draft criteria was not really given any importance, and which was later on included in the criteria which were modified. There were actually 2 modifications, and this is the final criteria which was published. And besides the ANCA vasculitis, 3 criteria. Recently, we had criteria for large vessel vasculitis also, which obviously is beyond the scope of this talk. So basically, if there is a nasal upper airway involvement, there is a cartilaginous involvement or hearing impairment, these are given different score as highlighted here. I don't want to go into all those details. I think every student of rheumatology must be already aware about these criteria. These are basically PR3 again here has been given a score of +5. And if there is a renal involvement, it also is given a score of +1, which was not there in the initial first criteria. And then if there is P-ANCA positivity or MPO positivity, and there is hypereosinophilia, these are given a negative score. Similarly, if there is a MPO positivity, it is given a score of 6. And if there is a PR3 positivity or hypereosinophilia, it is given a score of in minus. This is for microscopic polyangiitis. And for EGPA, if there is obstructive airway disease, if there is nasal polyposis, manifestation of allergic upper airway disease, or a monoitis multiplex, these are scored in positive. If there is hypereosinophilia, it is given a score of 5. But if there is hematuria or there is a PR3 positivity, these are given minus scores. Although I personally believe that there is a renal involvement, which is also seen in patients with EGPA. But these are classification criteria. So these are applied to the patients where a diagnosis has already been established. We recently presented the validation in a cohort of 302 patients. And I can tell you that besides the 2 presentation, I just shared one of the ACR presentation where we had challenged the draft criteria. These criteria seem to do better than the previous 2 draft criteria, which were, this was presented as a poster at the ACR, at the EULAR this year. So basically, the nomenclature system, the classification system, and the diagnostic criteria, there are practically no diagnostic criteria. So this is basically a work in progress. So when we have to make a diagnosis, we need to know the clinical spectrum of various manifestations, and those manifestations are there from head to toe. These can be eye involvement in the form of episcleritis, scleritis, proptosis, or dacrocystitis. There can be sinus involvement. There can be various pulmonary involvements, especially nodules in GPA. There can be kidney involvement and whole lot of involvements which are highlighted here. But the most common are these. And also, I'll quickly show you the pictures. The eye involvement might start with just a plain episcleritis with some pain and mild pain and redness, to a gory, very bad necrotizing scleritis, which are the pictures of which are shown here. Or these can present with proptosis, with a pseudotumor. You can compare this proptosis as compared to on the normal side. The oral cavity manifestations can be in the form of as if a pound of flesh has been taken away from the tongue or from the buccal cavity, as seen here. There can be manifestations in the form of strawberry gums. You can see these gums look like strawberry. There can be, if the sinus involvement or if the upper airway involvement in the cartilaginous inflammation persists for a period of time, then you can see there can be a nasal septal perforation. This is a nasal septal, there is the nasal cavity inflammation on PET examination. They can have sinusitis, recurrent sinusitis, but the most important history is nasal crusting, nasal bleed, nasal obstruction. They can have subglottic stenosis. The pulmonary manifestations can be in the form of thick-walled cavitating nodules. These nodules here, some effusions. Effusions are generally mild. They can have consolidation with air bronchogram mimicking pneumonias. They can have angiocentric nodules. They can have mass-like lesions. I have 2 patients on follow-up who were initially labeled to have bronchogenic carcinoma. They can have lung hemorrhages, and these hemorrhages might have a peripheral sparing. That's what we were talking about. This was a patient that we saw, a young female in pregnancy who presented for the first time with cannonball opacities, but all cannonball opacities are not malignancies, and this patient eventually turned out to be GPA. So the other manifestations can be peripheral nervous monoitis multiplex or mononeuropathies. This is again an imaging from pseudotumor. They can have pachymeningitis kind of presentations with lower cranial nerve palsies. This was one of the earliest descriptions of use of rituximab in patients with CNS involvement. The skin manifestations might be in the form of some papulonodular lesions to skin infarctions. And if you do a biopsy from here, this might also give you an evidence of vasculitis. This is again a very difficult to manage manifestation of GPA, where there is a hole eventually. I haven't put that picture here. And these are very gory, very mutilating lesions of GPA. They can have pyoderma gangrenosum type of presentations, hemorrhagic necrotizing bully. This was a patient from Bombay who had a PG kind of a lesion. The other general dictum is that Asians have, before we started publishing our experience, it was always told that Asians have MPO positive GPA, which is not true. Actually, all Indians predominantly have PR3 positive GPA, unlike MPO positive GPA, which is seen in Japanese patients. So this is something which is very important for us to know, and it was important for us to publish. Coming to the ANCA testing, prior to 2017 consensus, it was said that you should do ANCA both with immunofluorescence and with immunoassays, especially PR3 or MPO, third generation ELISA. Nowadays, it is said that since the sensitivity of third generation ELISAs is much higher, you should straight away go for PR3 or MPO. And if the first test is negative and still there is high pre-test positivity, it should be done with another kit. And if still the suspicion is high, then you probably can go with the second assay or an immunofluorescence assay at a center which is expert at doing the immunofluorescence. So coming on to the next part, which is management, the most important thing is we have to differentiate wolf in sheep's clothing, and the most important differential in a multi-system presentation is infective endocarditis. That the students should always look for a murmur or other manifestation which might suggest, and perhaps do an echo, either a bedside echo or a standard echo to try and rule out infections. Some subtle pointers which help in differentiating infection from disease activity are that if there is thrombocytosis, leukocytosis, then it is generally because of disease activity. Whereas if there is thrombocytopenia or there is coagulopathy, then you should always be more vigilant to look for infection as a cause of multi-system presentation. So what are the phases? The phases are in remission induction phase, followed by a remission maintenance phase, and then there is a long-term follow-up phase. But we know that these diseases, they relapse, and whenever there is a relapse, especially a major relapse, you might have to reinduce and go to the induction phase of treatment again. So taking you through the journey of evolution of management of ANCA vasculitis, it was Tony Fauci is credited with the description of use of cyclophosphamide in 1971, along with Sheldon Wolf and Johnson. But even a couple of months prior to this publication, there was a publication Pearson, who had also described the use of cyclophosphamide in ANCA vasculitis. But the major credit is always given to this publication from Tony Fauci and Sheldon Wolf. So what this cyclophosphamide introduction did was that if you look at the decadal trends, something which was in late 70s and 80s having mortality of upward of 80% had come down to less than 20% in the first decade of this century. But with cyclophosphamide, the major concerns were infertility and malignancy. We were touched upon these during the case presentation. Subsequently, the efforts were there to decrease the use of cyclophosphamide. So first trial was published in 2003, wherein in the maintenance phase, instead of cyclophosphamide, azathioprine use came into picture because of this trial done by David Jane, published in NEJM, which showed that in maintenance, azathioprine therapy was as good as cyclophosphamide. And after that, azathioprine became the standard of care for remission maintenance. And then subsequently, another trial was done by Christian Pennew of the French vasculitis group, which again was published in NEJM, which showed that in the maintenance phase, methotrexate did as well as azathioprine. And so you could either use azathioprine or methotrexate in the remission maintenance of ANCA vasculitis. Subsequently, there was always a debate between oral and IV cyclophosphamide, and we are all aware that oral cyclophosphamide has a much higher lower total cumulative dose. And Christiana de Groot's study was presented in Copenhagen ULAR and was presented the same year, which showed that oral cyclophosphamide, IV pulse cyclophosphamide, which had lower total cumulative dose and hence lesser risk of bladder toxicity, hemorrhagic cystitis, and bladder cancers. IV pulse was as good as oral cyclophosphamide, although there were some minor relapses, but they were non-life-threatening relapses, and the eventual outcomes were not different in those who were given IV pulse cyclophosphamide as compared to those who were given oral cyclophosphamide. Then the game-changing studies were published in 2010 in NEJM again, the RAVE and rituximab trial, which brought one more molecule, which was rituximab, into the picture as a remission induction, effective remission induction therapy. One was from the European groups, and the other one was from this was David Jane's group. This was John Stone's the group in the US. So both the studies showed that rituximab is non-inferior to cyclophosphamide as far as remission induction is concerned. But one thing which we all have to remember, that in RAVE trial, it did not meet the criteria of superiority. So in a naive patients who have not been exposed to therapy till date, we don't have any trial, prospective trial, which says that rituximab in induction in the initiation is better than cyclophosphamide. Although we have now studies which show that in relapsing disease, if you have to do a reinduction, especially if there is PR3 positivity, then perhaps rituximab is better than cyclophosphamide. So in the other thing that one needs to understand, that RAVE excluded very severe disease like lung hemorrhage requiring ventilatory support and advanced renal failure. So these were kind of excluded in the RAVE trial. These students have to remember. So even a follow-up of the RAVE trial was published in New England Journal of Medicine after 3 years, which showed that those who remained in remission, they continued to be in remission in 18 months. And the ones who had relapses, the relapses were more common in patients who had PR3 positive disease. So if there is PR3 positive disease, has higher number of relapses as compared to the ANCA vasculitis patients who have MPO positive disease. Another study, which was a maintenance trial. So in timeline, these yellow trials are the induction trials and the green trials are the maintenance trials. So another study was done, which was comparing the standard of care azathioprine with MMF, and MMF was inferior to azathioprine in remission maintenance. So MMF is not really a very good drug in remission, even in remission maintenance as compared to azathioprine. Although that standard of care also changed with Manretsan, I'll talk about it. Manretsan was published in 2014. So this was a published study from Louis Givan's group, again in NEJM, wherein it was shown that initially they gave 2 500 milligram infusions. Now only one is generally given. And then every 6 monthly, 500 milligrams of rituximab was given. And initially 2 milligram per kg azathioprine, then 1.5, and then 1 milligram of azathioprine was given. So it showed that the relapse rates came down from around 30% to 5% with rituximab. But David Jane wrote an editorial, what people had learned from Cyclops study, that is relapse a valid endpoint for these trials, and whether there is any mortality benefit or not. So the long-term follow-up of this study was again published by Benjamin Terrier, which showed that there was a mortality benefit at the end of 5 years in these patients of Manretsan trial. So the next question was, if you could tailor, again, those who were in remission in Manretsan 1 were re-randomized into the ones where a fixed schedule rituximab was given every 6 months, and individually tailored rituximab was given in patients who either had doubling of ANCA or had CD19 becoming positive. So either ANCA became double, or if ANCA had become negative, became positive again. So they were looking at 2 parameters. One was CD19 levels and the other one was the PR3 levels. So the question was that they said that at the end of 28 months, there was no difference, and the ones who had tailored rituximab infusions ended up having lesser number of rituximab infusions. But when we looked in between the lines, there were relapses even in the absence of, even in that paper, there were relapses even in the absence of circulating B cells, where the CD19s didn't really become positive. And CD19 lymphocyte level is not strictly associated with CD27 positive and memory B cell emergence. We looked at this data critically, and we asked a question that they took an arbitrary, to calculate a sample size, they took an arbitrary relapse rate of 35%, whereas the major and minor relapses in the Manhattan main trial were just 5% and 11%. And also the follow-up was also not for a long period of time. And what we suggested that perhaps if there was a, I'm sorry, I think there's some, if there was a longer follow-up, this might have become significant. So what David Jane, Louis Givon's group, they accepted that this was truly an arbitrary figure, because this sample size was calculated on an arbitrary figure because the Manhattan main trial results were not available at that time. If the Manhattan main trial results and the efficacy of rituximab was taken as per this trial, then this study was not really powered enough, or it was underpowered to detect an absolute relapse rate of 7%. And they were also candid that if there was a longer follow-up, there could have been a statistically significant difference. So although on paper, it looks like that scheduled therapy is as good as on-demand therapy is as good as the scheduled 6-monthly therapy, but this might really be true. And this has also been our own experience wherever we've tried to treat patient based upon the Manhattan 2 trial before we kind of read in between the lines. The other drug, this is a favorite of some of our physicians. MMF has been was used in a non-inferiority randomized trial in induction therapy. So what was shown that there was no difference in time to primary remission, no difference in time to first relapse. But when in the addendum, when we looked and digged into it, there were more relapses in the patients who had PR3 positivity, and in fact, relapse-free survival was also shorter in the patients in the MMF group. So it can only be used in non-PR3 milder disease. It can't really be used as an induction agent in a threatening PR3 positive ANCA vasculitis, even with this. Another study, which was done by Michael Walsh and published in NEJM, one of the largest trials, global trials done ever, was a plasma exchange or a trial, which is PEXIVAS trial. They looked at two things. One was, besides the plasma exchange, they also looked at the standard dose and a reduced dose corticosteroids. And they showed that there was no effect of plasma exchange on the primary outcomes, and there was no difference in the standard dose versus a reduced dose. Subsequently, there have been other studies also with which we can become confident of tapering the corticosteroid therapy quickly in these patients. Another trial, which again was from the Louis Givon's group, was a Manhattan 3 trial, wherein whether you give 6 monthly, continue to give 6 monthly rituximab, or you just observe. It was shown, and this was again the ones who were in remission at month 28 after Manhattan 2 were re-randomized to get rituximab infusions or placebo. And it was shown that the ones who got rituximab obviously did better, both as far as the relapse-free survival and a major relapse-free survival was concerned. And we again wrote a letter. We read into it that only those patients who didn't relapse, we know this is a relapsing disease, and the ones in which even in Manhattan, even in the RAVE trial, wherein they stopped steroid at 6 months, the relapse rate was pretty high. The Manhattan 3 reinduction was in patients who did not really relapse till 28 months. So despite getting the relatively better prognosis patients, there were still relapses even in the Manhattan 3 trial. So what we said that this and the 60 months data of Manhattan reaffirm prolonged maintenance therapy So because the main question is for how long do we really treat? And I think the drug-free remission seems to be a distant reality. So in our question response, Louis Givan's group again wrote that in the PR3 positive disease can be managed as chronic disease and warrants a long-term maintenance therapy with the rituximab, which is more than or equal to 4 years. So if somebody really has to treat for long, there is some written word which you can fall back upon, because many of these patients are likely to require therapy for a longer period of time, especially in a patient with a relapsing disease. So the other important study was again the rituximab as induction therapy in relapsing disease. This was a rituximab trial led by David Jane. This schema was initially induction therapy for 4 months, 375 milligram per meter square, and maintenance therapy 1 gram every 4 monthly. This is what I have been using for almost 10 years in the patients who have had a relapsing disease. But here in David Jane's group have been using this prolonged, and we've used it in only 4 to 5 patients maybe. Rest of them we could treat only with 500 milligrams every 6 monthly. And this was again the scheme. Initially, it was an observation study in a relapsing disease where in induction only rituximab was given, and in maintenance therapy, rituximab versus azathioprine was given. So this study, again, there was a induction regime which was 1 milligram per kg body weight, whereas 0.5 milligram per kg body weight. So we are going towards lesser and lesser corticosteroid doses. And in the induction phase, it was shown that by and large, at the end of 4 months, predominantly majority of the patients did well. And mind you, these were the patients who had relapsing disease. And even in the maintenance phase, rituximab was superior as far as relapse-free survival is concerned, and a major relapse-free survival is concerned. And adverse events there were no red flags with the use of rituximab as far as the rituximab trial was concerned. So we are not only going towards lower corticosteroid doses. There was a C5a inhibitor trial again led by David Jane. We know that is avacopan, wherein it was shown that at the end of a year there was a superiority. There were higher remission rates at week 52 and better, the GTI cumulative worsening scores in the patients who were given avacopan. This is still not available in India, and this is extremely costly. And the other flip side of this is that while in the avacopan the drugs were continued, but in the corticosteroid the steroids were stopped at some point in time. So I think that was one flip side. The other important thing that one needs to remember that there is always a debate between innovator and biosimilar drugs, and we have published our experience of biosimilar rituximab used in 77 patients, and we compared our data with the other multicentric trials, both in the induction phase and in the maintenance phase, and it has really done really well. You can go through those details. I don't have time to go through the details, but all that I can tell you is our biosimilars or biomimic, whatever you want to call it, or some intended copies, they have done well, almost as well as the reports published from the major trials all across the globe. So the other important thing that what is in the current position of Plex? So Plex is not really recommended in alveolar hemorrhage based upon the PEXIVAS trial, but as per this publication, because people said that there might be a subgroup of patients, and there is a renal risk score paper published in NDT, I think almost the same time, where people showed that with or without biopsy, you can have a score based upon which you can still do Plex. So there is a weak recommendation to give Plex in the patients who have baseline creatinine of more than 300 or those who are dialysis requiring. Basically, the creatinine of the more than 5.7 or those who are dialysis requiring, you can still consider Plex with the increased risk of infections. But as of now, with the current evidence, there is no role of Plex in alveolar hemorrhage and ANCA vasculitis. So this is a guideline which we wrote, Durga Misra wrote along with me and Shankar, wherein we've kind of compared all the different aspects. This was published in IJR. I think the residents can look up and pull this publication up or write to me, I'll send this publication. The question is that ACR guidelines recommended rituximab preferred agent, whereas other guidelines either say rituximab versus cyclophosphamide or cyclophosphamide alone. So we wrote, when these guidelines were published, we wrote that that you justified recommending rituximab over cyclophosphamide, but stating that a single course of cyclophosphamide carries substantial risk of neutropenia, bladder injury, and infertility. While this might hold true for oral cyclophosphamide, in our own experience, this did not translate into increased risk of infections over longer period of time, either in RAVE or Cyclops trial, or even in our own experience. So, and hemorrhagic cystitis and bladder cancer, we know that they are dose dependent. The guideline said, their reply was kind of a iffy reply, that this is a conditional recommendation based upon considering the efficacy, relapse, toxicity, and also patient's preference. So there is no any data driving it, but it is based upon the presumed toxicity, relapses. And I think a comment which kind of came with a little bit of surprise, that that whether one uses IV, which one is better, IV or pulse, is an area of debate. I don't think it is an area of a debate. That the debate was long settled with the Cyclops trial. And IV pulse cyclophosphamide have a significantly higher rate of relapse. This again, the Cyclops trial, these are non-life-threatening relapses, and eventually there was no, I have talked about it, there was no difference in the mortality outcomes. What these questions are published. You can take your own call based upon what you feel, but I still believe in a naive patient in our population where fertility is not an issue, cyclophosphamide is still a wonderful drug. And I think we've used it almost 400 to 450 patients of ANCA-associated vasculitis. So they end up by saying that our letter highlights many unanswered questions which still remain. Well, they have right to hide behind. I did this Twitter poll before the talk in Jaipur, in Jipmer Iracon, wherein you can see people out of 267 responses, and they were from all over. People still preferred oral cyclophosphamide, pulse cyclophosphamide over oral cyclophosphamide. And so basically, pulse cyclophosphamide and rituximab or rituximab pulse cyclo were almost nearly almost there. So this is the real world preference. At least this is a 2019 poll. And when we talk about combining, and Chetan had written that one needs to have a very good reason not to use IV cyclophosphamide. And Chetan, was the senior author of the EULAR EDTA recommendation published in 2016. With this, I will wish to end, and I think I'll probably wish to share that this book is available now, and those of the residents who would wish to dig deep into vasculitis can look up into this book. Thank you very much for your patient hearing. I'll wish to conclude that I would use cyclophosphamide or rituximab for emission induction. Rituximab will be preferred in young patient or where fertility is an issue, or the patient with relapsing PR3 positive disease. Rituximab has to be at a lower dose, has to be an agent of choice for emission maintenance. And we have already started using low dose corticosteroids. We really don't have Avacopan as of now available, and when it comes, we'll have to see what the costs are. Thank you again, and I'll be very happy to take up any questions.
Thank you so much, Dr. Aman. Your wonderful talk reflects the depth of knowledge and the vast years of experience. So I would just like to ask, is there any role of IVIG in, when vasculitis comes like an emergency with life-threatening situation before we can give other medications?
Ma'am, if I could borrow from what Dr. Bhamri used to say, he said that in an active vasculitis, IVIG is more of an apology. So once we have active vasculitis and we don't have evidence of overwhelming infection, I think we should go ahead and use steroids and more definitive therapies where the outcomes are better. But if there is evidence of definite infection, like you have culture positivity or you have, which is not very common in ANCA vasculitis subset as compared to lupus. Lupus, we are always debating whether there is infection versus disease activity. We are not really 100% sure. There, perhaps, but in ANCA vasculitis, generally, you are reasonably sure whether it is disease activity or infection. But once you have strong suspicion of infection or evidence of infection, there perhaps you might borrow time for some time where you treat the infection and then treat the, give the definitive therapy.
Yeah, fair enough. There are some questions in the chat box, sir. Any specific differences between subglottic stenosis that occurs in GPA versus that in relapsing polychondritis apart from associated features?
Basically, if you the clinical presentation, if it is subglottic stenosis, so the clinical features are the same. The imaging differences are there, as you could know that the anterior 2/3 is the cartilaginous area. So one is if there is a thickening in the initial stage would be only in the anterior 2/3 where the membranous part will be spared. And of course, whereas in GPA, the entire circumferential thickening will be there. Whereas in the later part, you will have a paradoxical movement where there is a laryngomalacia. That kind of a presentation, I don't think is seen in patients with GPA. And the other thing is rarely you might have overlapping RP and GPA also, which makes your rheumatologist's life difficult.
Yeah.
We've seen 2 patients with biopsy-proven GPA and classical cartilaginous inflammation all the years, sparing the lobules.
So how did you manage those patients?
Cyclophosphamide would be the choice over rituximab because rituximab data for relapsing polychondritis is nebulous. So perhaps there you would use cyclophosphamide, which works for both.
Like Mesna for bladder toxicity, how well do GnRH analogs perform in combating gonadal toxicity? Are they useful at all in the real world follow-up experience?
First, regarding the Mesna, there was a systematic review published in 2010. The use of by Peter Merkel's group in arthritis and rheumatology. Their students can look that up. The Mesna use has been borrowed from hematology use of cyclophosphamide, where the very higher doses were used. Well, you should discuss, because the evidence of use of Mesna, especially in the pulse cyclophosphamide therapy and the doses which we use, eventually we won't really use more than 6 grams. You have to discuss this with the patient. So when we use IV pulse, we haven't really we don't really use cyclophosphamide because we use 6 grams or 7 grams of total cyclophosphamide at max, and we haven't had much problems. The problems arise when outside some people use oral cyclophosphamide, and that has been taken for 6 months, year. We've seen a couple of bladder cancers there where oral cyclophosphamide has been used and used for very long.
This is a different question. Rows of NLR, neutrophilic lymphocytic ratio in vasculitis versus SLE.
I think there are a couple of studies, but people have looked at NLR neutrophil lymphocyte ratios, but I don't think you can take major decisions based upon these. These are as a research questions, but I think definitive decisions can't be based upon these. And of course, the other question was regarding GnRH analogs. Yes, you have to I mean, those are encouraged to be used in patients where, especially young patients, where you use cyclophosphamide.
Any situation where you would actually prefer oral cyclophosphamide?
Practically, no. The only situation where I will use is because we can use rituximab plus cyclophosphamide. We can have different doses of rituximab in maintenance therapy, 1 gram as compared to 500 milligrams 1 gram every 4 monthly, as compared to I would prefer using either these 2 in combination, or using these 2 plus methotrexate, or these plus leflunomide. Cyclophosphamide oral will be perhaps the last, where nothing is working and the disease is still active.
How to explain MPO negative but strongly positive P ANCA without any other underlying disease like inflammatory bowel disease?
There are for non-MPO and P ANCA, there are so many different causes. Drugs, some we know, some we don't know. So if it is non-MPO P ANCA, I won't really be giving too much importance to it unless you have a very strong clinical suspicion.
Would you biopsy the lung nodules if
Yes.
PR3 has already come positive?
Generally, yes, for a simple reason that if you're pressed against the wall and you need to treat aggressively in a given sub-situation where the patient is dying, then perhaps you might, if there is everything which fits the bill for active disease and needs treatment immediately, then you may not. Otherwise, it is always preferable to do a CT guided lung biopsy, because many of these nodules are peripherally placed. You can go from the posterior side or from the lateral side. It is always a good idea. We've had 3 patients of pulmonary tuberculosis in proven ANCA vasculitis and 1 NTM also of the lung. So, and they can exactly present like a relapse of an ANCA vasculitis. So you may get away by doing it in a full-blown case in the first manifestation. But if they come with a relapse, with the dominant lung nodules as the only manifestation, then you perhaps have to be wary.
Which conditions would you prefer using rituximab and cyclophosphamide both?
Perhaps part of it I answered. It is in a relapsing disease. So if I borrow my own experience, out of 450 patients, we've used in 4 or 5 patients where the disease was just relentless. And the problem then what we had is, in majority, we ended up fighting to control the infection. So it becomes very difficult, very, very difficult to control the infection.
Urolupus regimen does not indicate use of GnRH. What is your opinion?
Generally, people have now been talking about the association of infertility with the total cumulative dose that you give. And I think people, that if you are giving just a 3 grams in a milder renal involvement, where it's not, and the risk of is not very high and is not absolute. So that's the reason. So 6 grams, 7 grams, it may not really be that much. And when you're talking about ANCA, you first have to save the life, the only, then think about fertility.
How would you approach a situation where ANCA-associated vasculitis, where you're considering pulmonary tuberculosis also?
Very good question. If you only have a pulmonary manifestation with lung nodules, and we know that TB can also cause PR3 positivity. We had our own paper published in, I think we had published, presented at the EULAR. We took pulmonary TB patients, 7% of them had PR3 positivity. So even if there is a lung shadow and PR3 positivity, and there are no other features, and there are nodules only, then you will definitely do a biopsy and look for TB. One thing which helps you on radiology is that, and that paper we have written, I think it's basically, if there are mediastinal nodes, we looked at our data, we looked at the radiology of pulmonary TB patients and radiology of Wagner's patients. Generally, mediastinal nodes, significant diffusions are more, which goes in favor of TB. So if there are lung shadows, but there is no significant mediastinal adenopathy, then it is one soft pointer more towards disease activity than it being a pulmonary tuberculosis. Of course, this is not absolute, but then you have to look at other pictures also. But it has to remember, if there is sinus disease, if there is a renal disease, your life is easy. But if there is only pulmonary disease, it can at times be tricky.
This is Dr. Sandeep's question. You would like to ask anything else, Dr. Sandeep, regarding your question?
Yeah, sometimes in these situations, we are unable to rule it out at the end also, that between tuberculosis and unconstitutive vasculitis. How do you go along by giving both treating both diseases?
Generally, Sandeep, your point is well taken, but generally you will get some clue from here or there. So if you have only lung nodules, there is small chance that you will have PR3 positivity. But having active ANCA vasculitis and having active TB also, the clue will come from outside the lung or from whether there are mediastinal nodes present or absent. If there is something in the eye, something in the nose, some sort of subtle neuropathy which is now coming, and there are no nodes, then it goes more towards disease activity. But if there is significant mediastinal adenopathy, I strongly try to exclude TB and then take your judgment call. Fortunately, I haven't really needed to give both as of now. We've had a couple of patients where I had to tease out, but I don't remember treating for both.
There's a question from Dr. Varsha Bhatt. Which drug would you prefer in ANCA-associated vasculitis with scleritis as the only current manifestation?
Well, that's a very important question. Very good question. The thing is that biopsies were done in US from the eye many years ago, and they showed that in majority of those patients, especially those AAV patients, there is vasculitis which needs treatment with either rituximab or cyclophosphamide. So you shouldn't really be using methotrexate or milder drugs, because then there would be relapses. Better would be to treat with cyclophosphamide or rituximab.
Dr. Varsha, you want to ask anything else regarding your question?
No, ma'am, thank you. Thank you, Aman sir. Basically, I just wanted to know if scleritis was the only manifestation, like maybe in early AAV where you've only got scleritis. Even then, you would like to.
Yeah, the issue is if it is a necrotizing scleritis,
Right.
then I'll surely be giving
Aggressive
management
or rituximab. If it is just a small little nodular scleritis or all, generally, but eventually the experience is there. You use methotrexate in the beginning, you eventually end up using cyclophosphamide or rituximab later on. Very small subset you might get away with methotrexate.
Dr. Sanat has asked, where would you put in avacopan in the management algorithm? Do you think it's likely to be readily available soon?
Well, it is going to be a replacement of corticosteroids. So basically, you will use instead of steroids. So you'll use rituximab or cyclophosphamide, and you will use it in place of steroids. Well, there is still some concern regarding, if you look at the trial in between the lines, it is an unreasonable comparison. We did write a letter, but unfortunately that didn't get published. So in one arm, you continue to give drug, and the other arm, you stopped at a in between period. And then you're comparing the outcome at a later date.
Yeah.
So that's an unreasonable comparison. So we'll know the real world comparison when you have used either steroids or for the same amount of time. But it will obviously be used as a steroid sparing drug whenever it comes. You should use it instead of maybe some diabetic controlled sugars, or people have had IVIG, hypogammaglobulinemia is bothering, and there are infections and you don't want to give steroids. Those subset where you are concerned more of an infection as a problem, or because of uncontrolled diabetes and all, there you probably would be using this more.
Right. No, thank you.
Recurrent idiopathic episcleritis, ANCA negative. What should we do?
Well, episcleritis is never a major problem. Episcleritis, you can get away with topical treatment. If it is very bad or not, or it is bothering you a lot, so perhaps then you might use other drugs like azathioprine or methotrexate. Generally, it will, the ophthalmologist would be able to take care.
Dr. Sandeep is again asked, which regimen of rituximab you are more accustomed to, 500 milligram weekly or 1 gram every 2 weeks? It's always a difference between rheumatologist and nephrologist.
I think we use 1 gram into 2, and there are no trials which show that which one is better than the other. So if you look at the most of the recommendations also, they would say that perhaps 1 gram into 2 is as good as 5, and we use 1 gram into 2.
Okay, I think anybody else wants to ask can ask. Otherwise, okay, I think we had a fantastic session, Dr. Aman. Thank you so much for being with us today.
Thank you, madam, for very kind invitation, and thanks everybody for holding on till long, despite being.
It was just wonderful. Yeah, thank you, everyone, for being here today. Have a great Sunday.
Thank you. Thank
Bye-bye.
you.
Thank you.
Okay.
Thanks.
Bye.
You were a nice lecture.
Yeah. Good day.
Thanks, Sanat. Thanks.
Thanks, sir. Bye.
Thank you. Bye.
Bye.